diagnostic or therapeutic intervention is tailored on the patient characteristics. So in this view, using customized appliances is something really appreciated. We have no emergencies with respect to fixed appliances because we have no debonding, we have no problems with arch wires, we have no problems in relation to the comfort of the patient. And since we will reduce the chair time, because treating this kind of patients using this kind of appliances, we will spend a lot of time in defining our treatment plan, in defining the sequences of our virtual setup. And if everything is working, if we are able to design the right treatment plan, and if the patient obviously is a compliant patient and will help us, reducing the chair time, we will increase the office earnings. This is something that has been calculated by several sources. And we know that, for example, from a periodontal point of view, there is a huge amount of evidences demonstrating that the periodontal health during clear aligners treatment is always improved with respect to fixed appliances, even if they are lingual. This is a systematic review that I published with my group 5 years ago on the European Journal of Orthodontics, in which we have collected all the papers on this topic, and we have demonstrated that at the end, if we consider the indexes related to the periodontal health, working with aligners is always better than working with fixed appliances. This is true for adults, but this is true also for teenagers. This is another paper that was published by another Italian university, the University of Insubria, with Professor Alberto Capriolio and Luca Levrini, in which they treated two groups of teen patients that were matched for age, sex, and malocclusion. One group was treated with fixed conventional appliances. One group was treated with aligners. The primary outcome of this clinical trial was represented by the periodontal health indexes, and the result was that patients treated with aligners have always better periodontal health indexes with respect to patients treated with fixed appliances. So this is true not only for adults, but also for teens, also for our teens patients. This is all true, but at the end, we need to know if we can move, if we can be predictable and reliable in moving teeth, if the orthodontic tooth movement with aligners can be controlled in a proper way. So what about the clinical evidences? Well, we have to consider that in the last 5 to 6 years, a huge amount of scientific publication of moderate to high quality have been published about aligner orthodontics. And we have always to remember that an evidence-based approach means that we have always to consider not only the research, okay, not only the results of the best researches that we can find in PubMed or in other medical engines, but we have always to consider also our clinical skills and also the patient values and expectations. So remember that evidence-based orthodontics is not only research, okay? It's the connecting point between research, our skills, and patient values and expectation. We have always to remember this. And if we take a look on what we can do with clear aligner therapy, with CAT, and we consider what have been produced from a scientific point of view in the last years, the first paper that I show you is this paper published in 2014 on the American Journal of Orthodontics. A very nice paper, very well designed, written, and conducted. And you can see that the journal dedicated the cover of the issue to this paper, in which these authors, coming from Germany, from the University of Fribourg, Bonn, and Cologne, demonstrated that the force and moments generated by Invisalign aligners to control incisor torque, premolar derotation, and molar distalization are consistent with those values of force and moments that have been described in the existing literature for conventional orthodontics. So, in the same year, we have published a review, a systematic review on the Angle Orthodontist. The Angle Orthodontist is an open access journal, so you can Google, use Google or other search engine, and you can open for free the PDF of this paper. This is a systematic review in which we analyzed all the papers published from the beginning, from January 2000 to June 2014, from the introduction of Invisalign in the orthodontic world to June 2014, in order to analyze which movements, which kind of orthodontic movement are reliable and which are not. So in 2014, in the conclusions of this systematic review, we wrote that clear aligner therapy is effective in aligning and leveling arches. In anterior intrusion, it's comparable to straight wire technique, even if this conclusion was drawn on the basis of only one paper included in this systematic review. And clear aligner therapy is effective in controlling maxillary molars bodily distal movement with a limit of 1.5 millimeter. And CAT was not effective in controlling anterior extrusion, was not effective in controlling rotations of rounded teeth, and was not effective in controlling anterior buccolingual inclination. So a lot of limits were still against us. And last year, Professor Carlos Flores Mira and his group published an update of our review, considering all the papers written about aligners orthodontics. And as you can see, 19 of 20 included studies were Invisalign studies, and one was an F22 study. This is an aligner produced by an Italian company called Sveden and Martina. The University of Ferrara is the scientific arm of this aligner system. And they concluded that clear aligner was effective for minor anterior movement in the vertical, sagittal, and frontal plane. The outcomes were acceptable and comparable to fixed appliance for minor buccolingual inclination of upper and lower incisors. Most of the tooth movements were not predictable enough with clear aligner, except for minor movement, remember, minor horizontal teeth movement, and additional refinements are likely needed in almost every case to overcome current clear aligner therapy limited predictability. I just opened a window regarding refinements. Refinements are to be considered as optimization of our treatment. I work also with fixed appliances, and during the last months of every treatment, I have to bend my arch wires in order to optimize the finishing, in order to properly finish the case. And in this view, if I have to rebond some brackets, or if I have to bend a wire, this is not something negative, Refinement is the same. Refinement is represent the finishing bands or the finishing rebonding that I have to do in fixed appliances to properly finish my cases. This is the reason why I'll show you some cases that were finished without any refinement, but in most of them, you need to ask for some additional aligners in order to properly finish the case. But remember, we know, on the basis of what we have seen, that Working with aligner, we respect the periodontal health, and we can control in a proper way reduced amount of orthodontic tooth movement. These are the reasons why we started a cooperation with the perio department of my university in order to treat cases, periodontal patients, obviously that were stabilized from a perio perspective, were properly stabilized from a perio perspective, in order to, correct the pathologic tooth migration associated with the periodontal disease. And this is the case of Mr. Andrea. Andrea was 50 years old when he was referred to the ortho department by the perio. The chief complaints were represented by the aesthetics of the smile and the request of the patient to close the anterior spaces, because he told us that in the past he never had these spaces that obviously were the result of the perio disease. If we analyze the perio records, we can see that it was a severe periodontitis in the anterior region with a severe loss of bone in the anterior region. And accordingly to the last classification of periodontal diseases by Professor Tonetti, the patient was a stage 3 periodontitis that with a huge number of posterior teeth that were lost due to periodontitis. And this was the treatment plan defined after the etiological therapy of the perio department. So perio surgery was planned. It was represented by resective surgery on 4.7, then regenerative surgery in the anterior region, and extraction in the posterior region. Then orthodontics with alignment and space closure of the upper arch, and then at the end, the prosto-restorative therapy with further perio-supportive therapy every 3 months. So this was Andrea at the beginning. These are the initial X-ray records with the OPG showing us the missing teeth in the posterior region, the bone loss in the anterior, upper and lower front teeth with a mobility of type 1, 2 on upper incisors and lower incisors. And a skeletal class 1, as you can see, normal angle and an increased overjet and overbite. In order to correct all these aspects, considering that we have to work on in a perio patient, so we don't want to worsening any perio aspect, and considering that we should control the applied force in order to avoid any collateral effect, we decided to treat this patient with aligners. And this was with Invisalign aligners, and this was the clean check that was designed for Mr. Andrea. As you can see in the video, we performed several IPR in the lower arch in order to contract the lower arch, the arch length, and to obtain the overjet required to retract upper incisors, slowing down the movements. This is something that we can do with aligners. We know that the normal linear velocity of Invisalign aligners, at least, is at 0.2 millimeters per aligners. Working in these patients, we asked the technician to reduce the velocity to 0.1 millimeter per aligner. And we reduced the rotational movement to 1 degree per aligner. So we go back to what we have seen previously from the work of Professor Carlos Flores-Mir. We can control small amount of movement, and we can control this small amount of movement properly with aligners. So this is the reason why in perio patients we are using Invisalign aligners. We respect the periodontal health, and we can properly control small amount of orthodontic tooth movement, because we can reduce the velocity, then we can control with every aligner small amount of orthodontic tooth movement. We need also to properly control posterior anchorage when we plan anterior movement. Remember that orthodontics is always the same. Biomechanical principles are always the same. So we have always to consider an anchorage unit to properly control orthodontic tooth movement. So these are the progress of the case. We have asked Mr. Andrea to change his aligners every 10 days, and this was the applied protocol. So we plan a clean check, a virtual setup, in which angular movements were reduced to 1 degree per aligner, and linear movement to 0.12 millimeter, 10, 12 millimeter per aligner. And despite this planning, as you can see in this picture here, where you can see the aligner, we have a tracking loss in upper canines region, both upper canines. And this was the reason why we stopped at aligner 20, and we asked for additional aligners. The total number was from 30 to 31, so just one aligner more. And as you can see, we controlled better the posterior anchorage unit here, and also in quadrant 1. Again, mini movements, keeping the space for the future implant restoration. Again, IPR, and lower incisor torque control in order to properly finish our cases. And this was Andrea, Mr. Andrea, at the end of the ortho treatment. That was, it was lasted 15 months. As you can see, we had a good alignment, a good leveling of the arches. We closed the anterior and the lateral spaces with a proper control of the final intercuspation. In the upper left quadrant, you can see already an implant placed by the perio surgeons. Also on this side, they performed a sinus lift, and the patient was already ready for implant restoration also in quadrant 1. So you can see here the pre and post-treatment results. We centered the midlines, but I think that the most important thing was to properly control the orthodontic tooth movement of teeth with a very poor perio support. And again, the secret is to properly define the anchorage unit to reduce the amount of movement and to work with an appliance that can help you in keeping the periodontal health during the ortho treatment. And these were the final records at the end of the ortho treatment with a proper root control. Even during the retraction of the upper and lower arch, you can see the sinus lift here with the implants ready for future prosthetic restoration. We have collected a lot of cases from the perio department, and we have analyzed the orthodontic tooth movement requested to correct the pathologic tooth migration resulting from the periodontal disease in these patients. So we have collected a data set of more than 2,000 values corresponding to the movements of crowns and roots in the three planes of the space. And as you can see in this picture in pink, you have the average initial malposition of upper incisors and canines in the frontal plane, in the horizontal plane, and the average initial malposition of teeth of lower incisors in perio patients, and in gray the desired final position. And as you can see, in order to go from to pass from the pink position to the gray one, you need to control tipping movements that can be easily controlled with aligners, and you can control mini rotational and translation movements that you can easily control with aligners. So these are the results of a study that we are going to publish very soon, and this is the reason why we are continuing to use Invisalign aligners with this prescription, with this protocol in perio patients. So we know that we have some limitations. No, in the introduction, I've shown you the papers telling us that we cannot control in a proper way every orthodontic tooth movement. So probably one can think that we are using different forces. We are not using light continuous forces working with aligners. So probably the biology response could be different working with aligners. And the question is a good question because it was raised by this paper that was published more than 10 years ago by Daniel Cuncio and his group and published on the Angle Orthodontist. What they did in this paper, they have analyzed the post-retention outcomes using the American Board of Orthodontics grading system of a group of patients treated with fixed appliance, with buccal fixed appliances, and a group of patients treated with Invisalign aligners. And they analyzed with the ABO grading system the results at the end of the treatment and then 3 years after the end of the treatment in order to evaluate also the stability of after the conclusion of the orthodontic treatment. And if you read the discussion, of this paper, they write that the mean alignment of the Invisalign group was superior to the braces group before and after the retention phase. But few row down, you can read that even though the Invisalign cases relapsed more, they appear to have the same, if not better, overall alignment scores. So they are telling everything and the contrary of everything. So I think that this was the result of some prejudices behind the scientific paper. However, at the end, they discuss about the possibility that the differences could be in the characteristics of the new bone form, because with aligners we are working with intermittent forces, while with fixed appliances we are working with light continuous forces. But a few years later, the group of Professor Birte Melsen from the Aarhus University in Denmark published this paper. Published this paper, the one that you can see on your left, on the left of the screen, in which they analyzed a model in which they applied on these molar roots a light continuous force, the force called F1. And if you have not any occlusal force acting on the tooth, you can distinguish the pressure and tension areas, and the periodontal ligament is working like you are really applying light continuous forces. But if you are in this situation in which you have an occlusal contact that, for example, exert a force that you can have during swallowing or during clenching, for example, moving forward with the model, you can see that you cannot distinguish anymore tension and pressure areas. These areas are scattered along the root, and they conclude that they could not confirm the classical ideas of distinct and symmetrical compressive and tensile areas, and they also give us a very important information. because they demonstrated that even light continuous orthodontic forces are perceived as intermittent by the periodontium. Why? Because the periodontium is not a solid body from a mechanical point of view, but it has a viscoelastic behavior. And this is the reason why, even if you apply light continuous forces, the periodontium will perceive them as intermittent forces. Another study from a Japanese group published on the Journal of Dental Research in 2007 demonstrated that the application of intermittent forces will result in less cell damage in the periodontal ligament than did continuous force. And intermittent forces promote an increased concentration of proteins that are related to the orthodontic tooth movement. But since I would like to, I was really interested in the topic, with one of my students, Eugenio Gamero, that completed his postgraduate program 4 years ago. With his thesis, we published this paper on the angle orthodontist, in which we analyzed the concentration of several proteins like the rank ligand, the osteoprotegerine, the osteopontin, and the interleukin-1 beta in the gingival clavicular fluid of patients in treatment with Invisalign aligners. The rank ligand, as you have seen in this video, it's the activator of the osteoclastic activity. So binding to the ligand on the osteoclast surface, it will activate osteoclasts. So this will result in the activation of the bone modeling and remodeling processes behind orthodontic tooth movement. But the rank ligand is important also to generate osteoclasts from the precursor cells. And this is a very important, again, even if we are talking of only of orthodontics. And we analyzed also the concentration of another protein, the so-called OPG, osteoprotegerine. And the osteoprotegerine, as you are seeing in the video, can bind the rank ligand, avoiding any further link between the rank ligand and the ligand on the osteoclastic surface. And this is the mechanism with which the bone modeling and remodeling processes behind the orthodontic tooth movement are regulated. And this was the reason why we analyzed the concentration of these proteins in the gingival clavicular fluid. And the conclusion are that the biology is always the same. Our results were the same result described in previous study for fixed appliances for light continuous forces. So this just to confirm that if bone cells cannot distinguish if we are working with thermoplastic aligners with night-eye arch wires or stainless steel arch wires, at the end the biological response is always the same. So the conclusion of the work by Daniel Kuncha can be rejected. So limitations are not related to biology. This is the first point. I show you another case, the case of Angela. Angela was 25 years old when she came to our department, and she was a patient asking for an Invisalign treatment. She was very well informed. She collected a lot of information on the web, and she was very, sharp in deciding what was right for her. The chief complaint was the position of upper incisors. And she was asking for Invisalign, and this is one point suggesting that we are talking with a smart person, because she's a makeup artist, she's working in the fashion world, and she's traveling a lot. She, for her job, travels a lot between Italy, UK, US, Emirates. So she was looking for an orthodontic therapeutic possibility suitable with her job. And this was the reason why was one of the reasons why we decided to treat her with aligners. The other reason was that we were collecting patients for a study that I'll show you later on. And as you can see, we have a class 2 malocclusion with class 2 also canine relationship with an increased overjet in class 2 division 1. She's also skeletal class 2 with a normal angle, with an overjet greater than 10 millimeters. We have also third molars in the OPG. Obviously, the ideal treatment for Angela was a combined orthosurgical treatment, but as I mentioned before, we have also to consider patient values and expectation. And she is a nice face, okay? The profile is not excellent, but she is a nice face, and she has any aesthetic issue in relation to her face. So it was not our intention to generate some problems. So we obviously offered to her this possibility, but we altogether decided to move toward a camouflage treatment, a class 2 camouflage treatment. And so we decided to design this clean check for her. So extraction of third molar, sequential distalization of the upper teeth, and as you can see, we have attachments on all the distalizing teeth from canine to second molar. We have aligner cutouts in order to use class 2 elastics that are very important, as we will see. I'll show you again the clean check. With a sequential distalization, 50% sequential distalization. That means that the second molar starts its movement. When it reaches the 50% of the movement, the first molar starts. When the first molar reaches the 50% of the movement, the second premolar starts its movement, and so on, till we plan the en masse retraction of the anterior teeth. And you have seen also a final jump simulating the effect of the class 2 elastics mechanics. This is the two-dimension table showing you the sequence of movements and showing us the sequential distalization. As I told you, the second molar starts its movement as first teeth moving. When they reach the 50% of the movements, the first molar start their movements, and so on. The upper right canine starts early its movement because the patient has a concern related to the inclination of this canine. So I gave her an aesthetic start, the so-called aesthetic start, moving from the very beginning this tooth in order to show her some changes in the front teeth, because we have to consider that with this kind of treatment, we are recovering spaces in the posterior in order to align the anterior. So we need more or less 1 year before they can see something changing in the anterior, and we know that the patient will observe himself or herself every morning in the mirror. So we have to keep very high their motivation, showing them pictures, taking pictures at every appointment in order to show them the progress of the therapy, the improvement in the posterior, in order to keep their motivation very, very high. The case of Angela is a good case to show you the results of our experience, both in the clinical and in the research setting, in order to optimize the protocol that we are using now in class 2 non-extraction treatment with maxillary molar distalization. We have used the finite element analysis, some mathematical models that you can see here in this picture to analyze the effect of distalization, as you can see here, without any attachment, with attachments only from canine to first molar, and with attachments from canine to second molar. The arrows are showing you the displacement. They are not forces, they are showing you the amount of displacement, and the red color indicates a huge amount of displacement. So if you are planning here to distalize the second molar, as you can see, you will have a distal tipping of the second molar, and you will lose anchorage in the anterior. If you use rectangular attachments, you reduce the amount of anchorage loss in the anterior, and you can control a little bit better the movement of the second molar, but it's again mainly a tipping movement of the second molar. Working with attachments from canine to second molar, you have loss of anchorage in the anterior, especially for upper incisors, but you have a more badly movement of the molar. You have a movement in the distal direction also of the root. So this is the right configuration in order to control the badly movement of molars, and we need to use class 2 elastics in order to reinforce anterior anchorage to avoid this anchorage loss. Remember that when we plan distalization, we plan with aligners 0.2 millimeters of displacement, resulting in more or less 1 Newton force. But again, what happened with our protocol? When we use attachments from canine to second molars, these are the displacement that you can see in the mouth of your patients. So the second molar is moving distally, but you have loss of anchorage in the anterior. Why? Because the aligner is working like a compressed coil between the first and the second molar. Okay, and what happens when the second molar is at its 50% of movement and the first molar starts its movement? As you can see, you have a reduction of the distal velocity of the second molar. You have tipping movement with a good movement of the root of the first molar, so it's close to a badly movement, but again, you are losing anchorage in the anterior, so you need always to use class 2 elastics in order to avoid this loss of anchorage. Why? Because we have moved the coil from the space between the first and the second molar in the space between the first molar and the second premolar. Remember, we have not a coil, but this is an example showing you how the aligner, the plastic, is working. The elasticity of the aligner is working. It's like a compressed coil between these two teeth. But the crucial point is the starting of the second premolar distalization, because you see, you have loss of anchorage in the anterior, and we are working with class 2 elastics to avoid this, but we have also anchorage loss in the posterior. We are the second molar moving mesially, because the aligner is working like a compressed coil between the two premolars, but since the aligner is reducing its length, it's compressing the arch. So this is the reason why we have this anchorage loss in the posterior region, and it's like an elastic chain between the second molar and the second premolar. So this the aligner is working like a combination of a compressed coil between the two premolars and an elastic chain between the second premolar and the second molar. And again, while the first premolar will start its distalization movement, again, we are losing anchorage in the posterior. We are losing less anchorage in the anterior, but again, we are using class 2 elastics to avoid this. But the aligner is working with this kind of behavior, like a compressed coil between the canine and the first premolar, and an elastic chain from the second molar to the first premolar. And so on, even when we are distalizing the canine, or when we are retracting en masse the anterior region, it's like we are working with an elastic chain from second molar to second molar. So since we are all orthodontists, we know that when we use these kind of force modules in our clinical practice, we know that we have always to reinforce anterior and posterior anchorage. And as I told you, to reinforce anterior anchorage, we can use we have to use class 2 elastics. It's not an option. Class 2 elastics are something that we need to obtain good results if we plan this kind of treatment with aligner orthodontics. So class 2 elastics are able to avoid this kind of anchorage loss, but we have still no answer in how we can control this posterior anchorage loss. So let's go on with Angela. This was the initial situation. This was the fitting of the aligner 54 of 61 after 15 months. She's changing her aligners every week. And you can see that the fitting is perfect. The fitting is perfect on crown. The fitting is perfect on attachments. Why? Because we are working with a super compliant patient. We have designed a good treatment plan. The patient is wearing her aligners perfectly. She's wearing her class 2 elastics. And these were the elastics that I used with Angela. So 1/4 inches and 4 inches, sorry, and 4.5 ounces as force, with a button bonded on the lower first molar and cut out on the upper canine. And I ask my patients to wear the class 2 elastics 22 hours per day. So I ask them to wear the aligners 22 hours per day, and I ask them to wear class 2 elastics for the same time, 22 hours per day. Remember that we are Italian, we are creative, we are artists, you know. So if I ask my patients, if I tell my patients, you can wear the aligners for 20 hours, they probably will wear the aligners for 12 hours, only at night, just sometimes, you know. But I have to ask their commitment, their maximum commitment. So if I ask 22, probably I will obtain 18, 20. That's a good time. 20 is the limit. Okay, so I always explain them that 20 is the limit. So please keep an average aligner wearing of 22 hours per day. And the same for class 2 elastics. And this was Angela. At the end of the treatment, we have a molar class 1, canine class 1, good smile arc. She was very happy. I was very happy. And this was the protocol that we used for her. So the treatment was concluded in 18 months without any additional aligners, just with one set of aligners. Again, we had a good virtual setup. We had a good compliant patient with aligners and elastics. And the protocol was to change her aligners every 14 days till the second molars were in their final position, then every 10 days till the first molars were in their final position, and then every 7 days till the end. This was, these were the initial and the final lateral X-ray, showing you the improvement of the lower third profile. The superimposition is showing us the amount of molar distalization and good control of the upper incisors. And this was Angela, 3 years post-treatment. She's still in retention with the thermoformed retainers. As you can see, the result is stable. Her smile is always a very nice smile. She's a super nice girl now. And, you know, everything was fine. I'm happy with the results of this study, of this case, but if I see the position of these molars, I'm not happy. And why the molars are tipped majorly? Because of this. Because as I mentioned you before, the starting of distalization of second premolar is crucial, because it represents the situation in which we are losing anchorage in the posterior. So we know that with class 2 elastics, we can reinforce anterior anchorage. But what about posterior anchorage? In order to reinforce posterior anchorage, what we do now is to ask our technician to apply 5 to 10 degrees of distal crown tipping on molars when premolar distalization starts. So we are asking for a virtual gable bend, okay, in order to keep a good positioning, a good final position of upper molars at the end of treatment. So I repeat again, in order to reinforce anterior anchorage, we need class 2 elastics. To reinforce posterior anchorage, please ask your technician to apply for 5 to 10 degrees of distal crown tipping when the distalization of premolars will start. And again, in order to apply this information, you need, as I show you, attachments. You need attachments from canine to second molar. And I show you another case, the details of another case, the case of another girl in which we had this, very poor class 2 relationship, mainly related to the rotation of molars, but in which we started to move, for example, the anchorage of upper class 2 elastics from the hook on the canine on a button on the first premolar. Why? Because we had the sensation that the control of the anterior anchorage and posterior anchorage was improved with this kind of anchorage. And these are the progress after 12 months of treatment. You can see the intercuspation is nice. Also, the orientation of the upper first molar is almost perfect. Sorry. We are using now, and we suggest now in every class 2 case to use class 2 elastics with this diameter, 3/16 inches and 6 ounces force, from a button on the lower first molar. And in this case, we were working with buttons on the first premolars. Now I'll show you why we are using cutout hooks on the first premolar. And please take a look at the lower first molar, in which we have the button on which we can anchor the class 2 elastics. We have always a rectangular vertical attachment on the mesial cusp. Why? Because we have to counteract the mesial tipping tendency of the lower first molar, resulting from the effect of the class 2 mechanics. So we are always asked to have these attachments in order to avoid the mesial tipping of the lower first molar following the class 2 elastics vector. And this was the final result in 19 months with a proper class 1, molar and canine class 1, good alignment in the anterior. She was ready for the restorative here around the laterals. And this was the final result. So we had a class 1, but also you can see how the smile arc was improved in a significant way, and how the aesthetics of the face of the patient was improved a lot. Only in 19 months with aligners, attachments, and class 2 elastics. In this case, we had a refinement stage, but it was a minimal refinement stage. As I told you, what we do now in these cases is to use the class 2 elastics anchored on an aligner cut on the first premolar. These pictures are showing you the deformation of the aligners. As orthodontists, we know everything about night-eye archwire deformation. We know everything about stainless steel archwire deformation, but we do not know anything about aligner deformation. And this was the first study in which the first independent study showing you how an aligner is working when you are distalizing an upper second molar. Please be focused on the picture that you have on the right side of your screen. We are distalizing an upper second molar, and the arrows are showing you the deformation of the aligner when we are working with a class 2 elastics bonded on a button on the upper canine. You see that the aligner is working against us. The aligner is engaged to distalize the second molar. The resulting deformation of the aligner is producing these vectors. So in the past, people from Align Technology told us that distalization is built into the aligner. This is not true, as you can see. This is not true. The aligner is working against us. And this is the reason why working with button bonded on upper teeth, canines or premolars you have always loss of anchorage. You have not a proper control of the anterior, for example. You are not able to intrude the incisors or to control the torque information in a proper way. While, as you can see on the left side, if you are using your class 2 elastics on an aligner cut on the first premolar, you see the deformation while you are distalizing a second molar. The deformation of the aligner is working with us, is working with our distalization. The deformation is more prone to promote the distalization that we have planned. So this is the reason why we have changed completely our protocol with respect to what we have wrote in the past, also in scientific papers. And now we are working with this protocol. So the elastics that we apply are always the same, 316 inches, 6 ounces forces, from the very beginning. Because when we plan the distalization of the second molar, from the first stage, we tend to lose anchorage in the anterior, so we need to use a class 2 elastic anchored in the anterior, in the upper premolar, in order to have this kind of deformation supporting our distalization. So we have defined a biomechanical protocol, let me say, in order to treat these cases. And this protocol is the result of these mathematical models, but it's also the result of a huge amount of patients treated with this protocol. So when we plan this kind of treatment, we always plan the third molar extraction. Then we plan a 50% sequential distalization, as I show you with the case of Angela. We have always attachments from canine to second molar. If you are working with Invisalign aligners, if you have optimized attachment on these teeth, it's perfect. They are working. If you have not attachment, please consider to use rectangular and vertical attachments. Class 2 elastics, 316, 6 ounces on upper aligner cuts and on button on the lower first molar. And what we have analyzed from a mathematical model and what we have also demonstrated from a clinical point of view is that we need to use class 2 elastics on a hook on an upper first premolar till the end of the upper first premolar movement. Then we move the elastics on the upper canine, always on the aligner cut. So we do not use buttons on crowns anymore in the upper arch. And if possible, we plan an aesthetic start. So if we want to give some aesthetic satisfaction to the patient from the very beginning, we can plan some tiny rotation of upper incisors or canines in order to provide them some aesthetic satisfaction from the very beginning. The protocols was published just a couple of weeks ago. You can find, this is an open access paper. So if you use Google and you cite my name, Tommaso Castroflorio, and Applied Sciences, you will find the access to the MDPI website, and you can find this paper and you can download for free the PDF. And you can find a full description of the protocol with all the mathematical models that we used in order to control in a proper way upper molar distalization in this kind of treatment. From a clinical point of view, okay, mathematical models are okay, but from a clinical point of view, we have collected more or less 30 cases. And we analyzed the dentoskeletal effect of this kind of approach in real patients. So we analyzed pre- and post-treatment set tracings in order to measure the amount of maxillary molar distalization, the control of the inclination of upper incisors. And in the picture on your right side, you can see the number showing you that in average, we obtain a badly molar distalization of 2.5 millimeters for the second molar, 2.2 millimeters for the first molar. with a reduced amount of intrusion, 0.3, 0.5 millimeters of intrusion that was unwanted. This is probably the result of the bite block effect of the aligners. With a very reduced amount of molar tipping, we are around 1 degree, 2 degree for the second molar, and good control of upper incisors. Since we have this reduced amount of molar intrusion, we can control distalization in these cases without any change in the vertical height of the lower third of the face. As you know, when we plan distalization with other techniques, we have always an opening of the intermaxillary angle. With this technique, we can avoid the opening of the angle. So in a normal angle patient, we can keep the normal angle value. And the conclusion of this paper, this is another open access paper, Progress in Orthodontics 2016. Again, if you Google my name, Tommaso Castroflorio, and Progress in Orthodontics, you can find the access to the PDF, the free access to the PDF of this paper. So 2.5 millimeters are enough? Well, if we analyze this book, Evidence-Based Clinical Orthodontics, that was published in 2012 and was not updated. So it means that we have no news regarding the amount of average badly molar distalization that we can obtain with headgear, with tooth-borne anchorage appliances or bone-borne anchorage appliances. As you can see, we have always no more than 2 to 2.5 millimeters in average. And Miles and Rinchus are telling us that intraoral appliances are more effective than headgear, and molar tipping and loss of anchorage are always present, while, again, we have the same amount of badly movement of molars, so 2.5 millimeters in average. We have a very reduced amount of molar tipping and good control of incisors. So we can use with this protocol aligners in class 2 non-extraction treatment in which we want to correct properly the molar relationship and the canine relationship. Can we use an aligner for anterior extrusion? I'll show you several systematic reviews telling us that aligners are not so effective in extruding anterior teeth. And again, if we refer to the most recent high-quality systematic review published on the topic by Professor Carlos Flores-Mir, he's telling us that clear aligner therapy is effective for minor anterior dental movements. The anterior extrusion is not so predictable. So let's start with another case, the case of Eduardo. Eduardo was 24 years old when he came into our department. And, our consultation was probably the third or fourth consultation. Because he was really well prepared. He was looking for, some camouflage treatment because every orthodontist that was visiting him previously always suggested, in the right way, a surgical approach, and I totally agree with this kind of approach. But again, the patient is does not want surgery, so the challenge was to find a camouflage treatment for this patient, in which we have an anterior open bite, a constriction of the upper arch. You see also the pictures with lower lip incompetence. We have an atypical swallowing, and so we have also some functional aspects to consider in the correction of this malocclusion. If we take a look at the initial X-ray records, we can see that Eduardo is a skeletal class 2, open small open angle patient with a clockwise rotation of the mandible with a typical swallowing. So this was the reason why we decided to treat her, and I'll show you in a while the treatment plan, but also from an orthodontic point of view, but also with the cooperation of a speech specialist in order to try to recover a little bit the atypical swallowing. So this was the clean check. We decided to treat Eduardo with aligners. And you can see that we have attachment on all the upper and almost all the lower teeth. Sorry, also in all the lower teeth. I'll show you again the clean check. And you can see I planned also posterior intrusion. This is the reason why you can see the virtual models floating in the space. This is a limitation of the software that cannot simulate the contemporaneity of intrusion and the other orthodontic movements. But you can see the open bite was managed planning a maxillary expansion, a small distalization on the upper left quadrant, posterior intrusion and anterior extrusion. Regarding the posterior intrusion, we know that the predictability of Invisalign aligners at least is 1 millimeter per arch. So a maximum of 2 millimeters can be planned in a reliable way with aligners. Regarding vertical extrusion, Align technology is telling us that we can extrude with a limit of 2.5 millimeters. We will see if this will the truth or not. So this is Eduardo, 18 months after he was treated with the aligners, with the attachments. You see that we are at the end of the stage 1 of the first set of aligners. And in order to improve the posterior intercuspation, I do not ask for additional aligners. I can cut the last aligners distally to the canines, for example, place some composite buttons and working with intercuspation elastics, triangular elastics with a triangular geometry, as I do in my fixed appliance therapy, asking the patient to visit me every 10 days maximum, because these teeth are free to move in the space, just controlled only by class 2 elastics. And once the intercuspation has been improved, I can ask for a small amount, 5 to 6 additional aligners to improve further the final intercuspation. And this was Eduardo at the end of treatment that lasted for 21 months. A result that was obtained with the logopedic intervention, so the speech specialist intervention, working with aligners, attachments, button, posterior intercuspation elastics, and something more. As you can see, the smile arc has been improved a lot. We can see some gingival display now. Also, the lower third of the face have been improved a lot. Remember the face of Eduardo at the beginning. It was clear that we had some lower lip incompetence. Obviously, the profile is always a class 2 profile. We are talking of camouflage treatment. But in the frontal view, the aesthetic of the lower third of the face was improved a lot. However, you see that at the end we have some fixed retainers on the upper and on the lower. And we had a huge amount of maxillary arch development, close to 3 millimeters here. And we know from the existing literature that when we plan maxillary arch development, let's say maxillary expansion in non-growing patients, we know that with respect what the prescription that we made, we in average are going to lose the 25% of the information. How can I improve the predictability of the maxillary arch development in my patient? Remember, that when you analyze this publication, the authors never talk to us about the use of attachments. And we have always to remember that biomechanics is always the same. So if we plan to move buccally this molar just with an aligner that is working only on the crown and at a certain distance from the center of rotation of our tooth, we are for sure planning a tipping movement that will result in a loss of information in a posterior open bite, because the buccal cusp will be moved upward, and at the end we cannot see what we have planned. But considering biomechanics, if we plan the presence of a buccal attachments on which we ask the technician to apply an exclusive force during all the buccal movement, we can create a counter moment controlling the buccal movement of the root, so the buccal root torque, and keeping the vertical position, the right vertical position of the buccal cusp of the molar. Okay, so remember, biomechanics is always the same. We have always to use our knowledge. So this will increase the predictability of the maxillary arch development that I can obtain with aligners. But in this case, we plan more or less 3 millimeter in the 2.4 region. And we know that this kind of design with the buccal attachments is predictable for maximum 2 millimeters of expansion. But what if we plan more than 2 millimeters, and if the period support, like in the case of Eduardo, is poor? So we have designed a protocol with our period department again, in which we plan also corticisms and bone graft. So Eduardo was not happy about major surgery, but we proposed him, okay, we can run a camouflage treatment, but you have to consider some minor surgery in order to obtain the most reliable result that we can plan for you. So we worked, and again, this is another open access journal, in which with Dr. Alberto Diaspro, the surgeon with which I work since a long time, he designed a very original technique in order to avoid any wound of the marginal periodontal support. So we plan this kind of treatment. And in order to plan this kind of treatment, in which we plan also corticism, we refer to a paper, a very nice paper from Mariana Evans, that with a very simple formula, and obviously we need a CBCT, we can decide if we have an envelope in which we can move the roots, or like in Eduardo, we are in a situation like this, in which if we plan buccal movement of the root, we need some cortical drift, or we have to increase the bone envelope in which we can move our roots. From a photogrammetric point of view, that has no any scientific value, just to show you the amount of expansion of the upper arch of Eduardo, showing you the final result. The biological rationale of this kind of approach is known, has been published. At the end, what we obtain is a cortical drift with new bone formation. And I suggest you to read this book, Clinical Guide to Accelerate Orthodontics, from the group of the New York University, in which you can find all the background information explaining the biology of this kind of approach. And this is Eduardo before and after treatment. You can see how the lower third of the face changed. And the only surgery that we performed was the corticism in the upper lateral quadrant on both sides. And this was a cut, a CBCT an initial CBCT cut in the 2.4 region. And this was the CBCT took just 2 years after the intervention, showing you the new bone that is organizing and the roots that are into the new envelope bone. Obviously, we need long-term observation before designing any conclusion, but the preliminary results are very, very promising, as you can see also in the pictures of the face of Eduardo. This was the final lateral X-ray, showing you a nice overbite and overjet, good control of the inclination of the upper incisors, good parallelism of the roots in the final OPG, and the pre and post lateral picture showing you the amount of anterior open bite that was closed only with aligners and attachments. We have never used anterior vertical elastics. We used just posterior intercuspation elastics in the final stages of the treatment, just to increase the stability of the final intercuspation. And in this picture, you can see the perio support. And here you can see the wound of the surgical intervention corresponding to the lateral frenula. But you can see the periodontium, the final periodontal health is excellent. Even if we have planned a good amount of expansion of maxillary arch development, we do not have final recession in the upper lateral teeth. So let's see the superimposition of the initial and lateral X-ray. Considering the extrusion of anterior teeth, we had upper and lower incisor retroclination, as you can see here. The upper incisor total extrusion was 4 millimeters, but it was mainly a combination of, it was mainly a relative extrusion related to the retroclination and a little bit of pure extrusion. While for the lower incisor, we had a pure extrusion of 2 millimeters and a little bit of retroclination. Furthermore, we had an intrusion of posterior teeth that was planned, producing a counterclockwise rotation of the mandible, so an auto-rotation of the mandible, and the vertical jaw relation passed from 34 to 32 degrees. So the intermaxillary angle was closed of a couple of degrees. That is nice. That helped in controlling the anterior open bite and to reduce also the lower lip incompetence. Obviously, also in this case, we worked with the speech specialist. And this was the result 4 years post-treatment. So you can see that the intercuspation is stable, the anterior position is stable, and also the lateral X-ray took 4 years from the end of treatment, is showing us a good stability of the final result, and the patient is in retention with thermoformed retainers that is wearing every night. So we can extrude with aligners, but as I show you and I can anticipate you, there is always a combination of relative extrusion and real extrusion. So there is always a retroclination of upper incisors. Even in this case, we have analyzed clinical cases, but we have also analyzed mathematical models. And I'll show you some results of this analysis that will be published at the beginning of 2021. We have analyzed several configurations in which we have or not posterior anchorage attachments represented by rectangular vertical attachments from canine to second molar, with anterior rectangular horizontal attachments on the 4 incisors. And if we analyze the displacement, you can see that if we plan the extrusion of the central incisors, we see always this kind of displacement. We have always a tendency to retroclination of upper central incisors. And this is the deformation of the aligner. So the aligner is working with us. So Posterior anchorage, as you can see, is reinforced, so we have good control of posterior anchorage, and this explains you why if you plan posterior intrusion, you will have posterior intrusion while you're extruding anteriorly. But as you can see, the arrows, you have a displacement in the cervical area of the upper incisors and in the palatal area in the incisal edge region of the central incisor. So the final result is always a retroclination of the central incisors and many of the central incisors in a lower way of also of the lateral incisors. From a periodontal point of view, the force applied is a force of 60 gram that is described as optimal force level from a periodontal point of view when we talk about orthodontic forces. We obtained the same result that I described you for this configuration for the anterior rectangular attachments. Also for the optimized attachments, for the Invisalign optimized attachments in the anterior, and also for rectangular horizontal attachments in the lingual side. They represent the preferred ones of my friend, good friend Alessandro Greco, another aligner orthodontic speaker. And results are always the same. We have always a retroclination of the incisors, the type of attachment, the position of attachments has no influence. So regarding anterior extrusion, the system is not so efficient. We have always to consider posterior intrusion and always to consider that the target case for an aligner treatment, considering open bite patient, is a patient in which we have to retrocline incisors. So are aligners efficient in performing upper incisor extrusion? Well, if we are talking about pure extrusion, no, they are not efficient. We have always retroclination. Number, position, shape of attachments doesn't any influence on the force system? No, at least for the group extrusion of the 4 incisors. Posterior anchorage is preserved if we use posterior attachments. So we need attachments also in the posterior region. And these results were were supported by a clinical study of the University of San Francisco. This is a clinical trial in which they analyzed open bite patients treated with MBT appliances and fixed appliances and clear aligners. And the final result is that from a dentoskeletal effect, the results are always the same without any significant difference between the two techniques, with the exception of the extrusion of the lower incisors that was greater with aligners, with Invisalign aligners. But we are talking of less than 1 millimeter of difference. So from a clinical point of view, not so important. Okay. So the vertical dimension was maintained in this case because posterior intrusion was not planned. And the final result, as you can see, is mainly the combination of retroclination and extrusion of upper and lower incisors. I'll show you another case, the case of Nicola. A quite complex case because it's an anterolateral open bite that is the result of quite important tongue thrust. And Nicola already had orthodontics in the past. He had functional orthodontics when he was a kid and fixed orthodontics when he was a teen. He already had rotation with a tooth positioner, but at the end, this was the result. And again, he's looking for a camouflage treatment. Camouflage treatment that was also justified by the condition of his TMJs. He had signs and symptoms of osteoarthritis that were treated before starting any orthodontic treatment. So we applied the protocols of Professor Okeson in treating this patient. These are the guidelines that we use in our department. So before we have to control TMJ signs and symptoms, and once they are under control, we can plan orthodontic treatment. So this is a skeletal class 2 patient, open angle patient with a mandibular clockwise rotation, again, atypical swallowing. So as what we have seen for Eduardo, we applied the same protocol also with Nicola, so speech specialist for the logopedic intervention, and we designed a clean check in which, again, we plan a maxillary arch development with micro movement, as you can see. We do not plan any posterior intrusion in this case, and this was a mistake, but at the end, since we are talking about open bite patient in which we have mainly posterior contact, the bite block effect of the aligner is working properly in this case. So we have always 1.2, 1.5 millimeters of intrusion at the end, even if we have not planned this kind of intrusion. This is the initial CBCT of Nicola, and we have some problem in this region. So when we plan this kind of arch development in adult patient, in which we have, from a diagnostic point of view, the idea that the period support is not very strong, we always ask for a CBCT. And now with my friend Francesco Garino, we are working with the Research and Development Department of Align Technology in Moscow to combine the clean check with the DICOM data of the CBCT. And this is the clean check of Nicola superimposed to the DICOM data of his initial CBCT. And as you can see, considering the treatment plan that we have designed without any consideration of the CBCT, we will provoke severe periodontal lesions in our patients at the end of treatment on both sides, as we can see in the frontal view. This was the reason why, even in Nicola, we applied the same protocol that we have applied in Eduardo. So we planned core decisions, the bone graft, and we planned the expansion that was planned in the initial clean check. And these are the progress of Nicola. This was the situation 6 months after the beginning of our treatment. 10 months later, without any vertical elastics in the posterior or in the anterior region, just aligners and attachments and corticisms. As you can see here in the lateral frenula, on both sides, you can see the surgical wound. 20 months, we are almost there. The patient is changing its aligners every 7 days. So this was Nicola at the beginning. After 20 months, we are very close to the final stages of the treatment, in which we can ask some additional aligners in order to improve the intercuspation in this area. Okay, like we are going to bend our wires in order to improve the intercuspation in the canine and premolar region. And this was Nicola at the debonding at the end of our treatment after 22 months. With a good inter-arch relationship, good smile arc, good aesthetics of the lower third. Obviously, what we can do with orthodontics is important, but we have always to remember that open bite patients, open bite as a malocclusion as a multifactorial etiology, so we have also to consider the work of the speech specialist. This is the pictures of Nicola at the very beginning of the logopedic intervention with Dr. Piladieri. This was the result, the symmetrical result from the beginning, obtained after 3 to 4 months of exercise, daily exercises. And this is very important for the stability of our result. This is Nicola at the end of treatment, so the comparison between the beginning and the final pictures, the initial and final OPG, showing again a good root parallelism. We had any TMJ problem during the treatment. And this is the superimposition showing again a counterclockwise rotation of the mandible, an upper incisor total extrusion of 3 millimeters that is resulting mainly from the retroclination of upper incisors, a lower incisor pure extrusion of 1 millimeter. But at the end, we had also some changes in the lower third of the face because of the bite block effect of the aligners. And this is the comparison between the pre-treatment CBCT and the CBCT took 24 months after the corticism. You can see here the bone graft that is organizing. And again, as I told you, we need long-term observations, but preliminary results are encouraging. This is Nicola 3 years from the end of treatment. These are pictures that were taken in August this year. And also the lateral X-ray 3 years after the end of treatment is showing us the stability of the final result. The retention in this case is provided with an upper Michigan splint because we remember the TMJ problems that he had. So from a prevention point of view, we use the Michigan splint as a retention device, but also as a functional device that the patient is using at night. And a lower bag splint, so keeping the incisors and leaving the occlusal surfaces of lower teeth free in order to keep the vertical position of posterior teeth, and then to keep the intrusion. So after these two cases, I show you another case, a case of another study of Professor Ravinanda, on the cases treated by my friend Kenji Ojima from Tokyo. This is an open access paper. Again, if you Google Kenji Ojima and progress in orthodontics, you will find this free PDF published in September 2020, in which they analyzed the dentoskeletal effects of Invisalign aligner treatment in open bite patients. And the results are showing us that the open bite closure with clear aligners is the result of a combination of maxillary and mandibular incisor extrusion and maxillary and mandibular molar intrusion, leading to mandibular auto-rotation and reduction in anterior facial height. And these are the same results that we observe. So it's something that could be defined as reliable. Point 2 is very important. Remember, maxillary and mandibular incisors were also significantly retracted during treatment. So this means that, again, the target patient, the target open bite patient to be treated with aligners is an open bite patient requiring also a retraction of upper and lower incisors in order to obtain the best result that you can obtain. The last session of my lecture is focused on the rotation of rounded teeth. We know that rotating rounded teeth with clear aligners is something very, very difficult. And previous studies are telling us that the predictability of this kind of movement is very low. The mean accuracy is around 40%. A more recent paper by Kravitz is telling us that is around 50%. But again, there is a limitation of all those studies. They are not telling us if they are using or not attachments. So we analyzed several clinical cases, we designed some mathematical models, and again, we performed some measurements. And these measurements were published on Angle Orthodontist in 2019. Again, this is another open access paper. So if you go on the website of Angle Orthodontics with Google and you digit my name, you can find also this paper. So in these mathematical models, we are trying to derotate this lower second premolar without attachments, with a rectangular and vertical attachment on it, or with the vertical and rectangular attachment on the lower second premolar, but also on the adjacent teeth. And as you can see, the arrows showing us the displacement. Without attachments, you obtain this kind of movement. You obtain a little bit of a rotation of the second premolar, but you obtain a collateral effect, quite important on the lower first premolar on the other side. While if you have an attachment on the lower second premolar, you can see the main displacement is in this region, so it's working. But you have a huge loss of anchorage here, so the second molar on the same side is going buccally. While if you use a rectangular and vertical attachment on the lower second premolar and also on the adjacent teeth, you can control a little bit better the rotation, also the buccal movement of the lower second molar that is going to be a little bit intruded, but we are going to lose anchorage in the anterior. So we have to remember that when we derotate premolars, the anterior teeth are working probably as anchorage units. So we have to reinforce information in order to avoid these collateral effects. So we have to communicate with our technician in order to provide lingual root torque information, for example, in order to avoid these uncontrolled tipping movements in the anterior part. Also, the amount of activation is important. 1.2 degree of activation is the average activation provided by aligned technology techniques, while 3 degrees of activation was the activation provided by clear correct techniques. And as you can see, it seems that without attachment, this activation is working better with respect to this one. But we have always to remember the force released at the periodontal level. And working with this kind of activation, the periodontal is stressed a lot. The periodontal ligament is stressed a lot. Working with the attachment on only on the tooth that for which we required the rotational movement is showing us a better control with this kind of activation with respect to 3 degrees, in which we have more collateral effects. And working with attachment also on adjacent teeth, you know that the 3 degrees of activation is provided as also movements, quite important displacement also on the adjacent teeth. So it's always to work with small amount of activation from a rotational point of view, not only for the displacement that we can observe, but also remember for the periodontal ligament stress. In fact, in the conclusion of this paper, we underline that the configuration with the rectangular and vertical attachment on element 4.5 with 1.2 degree of activation seems to be the most efficient in rotating tooth, and that 1.2 and that anterior teeth seem to work as anchorage units. And we have to reinforce these anchorage units, providing, for example, lingual root torque information in order to avoid the collateral movement. And 1.2 degree of activation or less than 1.2 degree of activation seem to deliver force levels on the periodontal ligament which better fit with the optimal force paradigm of biology of tooth movement. This is the reason why, going back to the first case, to the perio case, I suggested you to reduce the amount of rotational movement to less than 1.2 degree, to less than 1 degree per stage, because we can control better micro movements, and we can control also rotational movement that are quietly difficult to control otherwise with aligners. Remember that with this picture from my friend Juan Pablo Gomez Arango from Colombia, that aligners are not smart enough to understand that you want to derotate these premolars. This premolar, for example, because once they are, the aligner is engaged on the crown, it will release forces in every direction. So we need surfaces on which the aligner can work, and these surfaces are provided by the attachments. So optimized attachments are optimized because we can apply forces and we can manage aligner deformation, providing forces supporting the movements that we have designed. So generating the moment that are favorable to the movement that we have designed. And we have always to remember that space is required. That this is another basic point of view. In every orthodontic technique, space is required in order to have movement. So remember that when some movement is not happening with aligners, you have always to check the friction in the interproximal region. I'll show you my last case, the case of Alessandra. Alessandra was 13 years old when she came to our department. As you can see, the upper crowding is very important. We have no space for the upper left canine. The oral hygiene is a serious issue, and we have tried with hygienists to improve our skills, but it was very, very difficult. And this was the main reason why we decided to treat her with aligners. And the most challenging movement in this case that was treated with for extraction was the rotation of lower canines. These lower left canine need a rotational movement of more than 50 degrees, 50 degrees, 54 degrees, while for this canine we are planning more or less 40 degrees of rotational movement. These are the initial records. So she's an open angle patient, small class 2. So we planned the extraction of the upper and lower first premolars. And this was the clean check that was designed for her at the very beginning, in which you can see we have reduced again the velocity of movement. This is the secret, especially when we need to burn posterior anchorage and to plan some mesialization movement that are other quite difficult movements to control. So this was the final position that was designed for Alessandra. And these are the progress. And, after 10 months, 1.3 is almost in its final position without any damage on the lateral root. We are very happy for this kind of movement. But you see that the lower first molar have a little tendency to molar mesial tipping movements. Why? While the lower canines have been controlled very well with optimized attachments, the initial clean check, the initial set of 20 aligners was where we used a rectangular and vertical attachment. Then with in this stage, with a new set of aligners, we have some optimized attachments on upper canines, lower canines, and premolars. But you see, we have this mesial tipping of the lower molars. Why? We have to remember that the aligners are plastic aligners. They are not stainless steel aligners. So they are characterized by a certain amount of elasticity. So when we plan the closure of an extraction space, we have to imagine that the total length of the aligner is reduced with respect to the effective arch length because we have to close the space. So the result is that the aligner will squeeze the arch, and this will promote some bowing effect that we have to manage in order to properly control the orthodontic movement. So one of the aspects that we have to control is the sequencing, the staging of the anterior retraction. We can plan an en masse retraction of the anterior canines and incisors, but shortening the aligner length too quickly will result in a bowing effect because the aligner will squeeze the arch length very quickly. What we can do is to apply the so-called frog protocol on the sagittal plane. So we ask the technician to move the canines for 2 millimeters. And for every 2 millimeters, we ask 2 degrees of distal root tipping in order to properly control the orthodontic movement. Then stop the canines, move for 2 millimeters the 4 incisors, and every 2 millimeters of movement of the incisor, we ask also 2 degrees of distal root tipping, and so on, till the closure of the extraction space. This means that the aligner will be reduce its length in a more progressive way. So staging is important. We have also, in order to avoid the bowing effect, to control the tendency of relative extrusion of the upper incisor. So we ask the technician to activate the aligner anteriorly, applying an intrusive force during the retraction of the incisors, and we always ask to have some lingual root torque information. So we know that the power ridges that are quite effective in our experience can be triggered by a request of a lingual root torque information of at least 3 degrees. So we always ask for at least 3 to 5 degrees of lingual root torque on the upper incisor during their retraction. Furthermore, in order to reduce this mesial tipping tendency of upper and lower molars in these cases, we always ask, and this is a thanks to my friend Kenji Ojima, this protocol was designed by him. What we do, what I have learned from him was to ask the technician to reduce the initial velocity of the molar of the 50%. So the mesialization velocity is 0.12 millimeters for the first 50% of movement. We need always to have a rectangular vertical attachment on this molar because we ask the technician to have a constant 5 degrees of distal crown tipping on the mesializing molar in order to counteract the tendency to the mesial tipping. And this was the final result of Alessandra, just with liners, attachments, class 2 elastics, recovering also the space for the final prosthetic restoration on the lower first molar. So we can control also complex movement. We can control also extraction spaces properly if we know biomechanics, if we know the potentials and limitation of the technique. We can control also the rotation of rounded teeth as these rounded lower canines. This was the amount of correction for the both of them, just with aligners and attachment without any auxiliary to control this particular movement. Staging is important, remember, so when we control rotation, we always ask less than 1 degree of activation of rotational movement per aligner. And this was Alessandra at the end of treatment, so with a nice support of the upper and lower lips, good control of the upper and lower incisors. So to conclude, I want to conclude with another publication by the Minnesota University team, guided by Professor Brent Larson, again published on the Angle Orthodontist. This is another open access paper that you can download. What they did, they analyzed the predictability of the clean check, analyzing and superimposing the final intraoral scan with the final stage of the correspondent clean check. And with a dedicated software, they analyzed all the difference in the trade direction of the space. So these are the conclusions. A maxillary arch expansion may not be fully achieved. Mandibular incisors tend to be positioned more occlusally than predicted. This means that intrusion cannot be fully achieved. Rotation of rounded teeth may be incomplete. Molar torque may not be fully achieved with maxillary second molars, often having a clinically relevant magnitude of more facial crown torque than predicted. Okay, but if you read the discussion of the paper, although the present results suggest that the intra-arch tooth position predicted by the virtual treatment plan is not consistently achieved by Invisalign aligners, and some limitation in the appliance system remain, they in no way suggest unsatisfactory treatment results. In fact, the only difference that was clinically significant, okay, was represented by the second molar maxillary, the maxillary second molar torque between predicted and achieved position. Okay, the only clinically relevant difference was this information. It's important for sure, but was the only clinically significant difference. We have to remember what they underline few rows in the following. So we have to use our virtual setup as instruments to design our biomechanics. So I work with Align, so I work with CleanCheck. And I've tried to show you this evening with my lecture how you can control some collateral effect, some undesired movement, asking for compensating movement, for example, that you have to design in your CleanCheck. You have to communicate to your technician, or you have to work with your 3D controls in order to provide this information that cannot be provided by a technician, because you are the orthodontist, you know the biomechanics, you know orthodontics, okay? And we have always to remember that aligners are not managed by a wizard. So we have to plan our treatment plan, we have to plan our biomechanics. That means that we have to define if we need attachments or not, if we need auxiliaries or not, in order to obtain better treatment outcomes, in order to obtain what we have predicted, in order to go closer to what we have predicted with our treatment plan. So, sorry. Our limitation, we know that some limitations still remain. Our limitation related to the technique, well, we have to remember that aligners alone are not an orthodontic technique. We need attachments. We need auxiliaries. So if we consider this kind of approach and we consider aligner orthodontics as we need to consider it as a comprehensive orthodontic treatment with auxiliaries, with DADs, with elastics, with all the attachment that we need, probably we have some limitation, probably that are mostly related to the lack of knowledge of aligner deformation, and we are working on it. But we can reduce we can control most of these limitations. Limitations related to the biology? No, because the biology of orthodontic tooth movement is always the same, remember. So biology is always the same. Cell bones are not aware if we are working with night eye, with braces, or if we are working with aligners. Limitations are mostly related to the lack of research, but there is a growing interest in the field, as I show you, and the lack of standardized protocols, but we are going to fill the gap. Our research with the mathematical models are designed to provide to the clinical world, to introduce in the clinical field some predictable protocols. I want to conclude showing you a brand new book that will be published very soon by Elsevier. So please stay tuned on their website. The editor-in-chief is Professor Ravinanda. I'm one of the co-editors with my friend Francesco Garino and with Kenji, my friend Kenji from Japan. We have wrote a book that has been entitled Principles in Biomechanics of Aligner Treatment. It's not a book about Invisalign. It's a book about aligner treatment. So we are talking of several aligner techniques. We are expanding the biomechanical principle that we need to apply in everyday clinical approach with this kind of appliances. And as you can see, chapters have been written by super experts in the field, from Sean Carlson, Professor Lapatki from Germany, by Alessandro Greco, Wada Sabuni, that you already know, Kenji Ujima, Kami Malekian, Ravinanda, obviously, the group of Jacopo Cioffi and Ali Tassi from Canada, Ivo Marek, my friend Ivo Marek, and Josef Kusera and Ivo Marek from Czech Republic, and Benedict Wilms and Jorgo Schwarze from Germany, and again Luca Lombardo from Italy. So please stay tuned. We hope to have the book. Well, all the chapters have been already written. We are in the final stages of production, so we hope that the first months of 2021 we will have this book available for everyone. So stay tuned on the Elsevier website.